director for the Northwestern McGaw Family Medicine program at Humboldt Park. So I'm at a program that's a teaching health center program where we're focused on working in a community health center. So I went into family medicine because I always knew that I wanted to do primary care. I had a personal experience where a family member was misdiagnosed for a really long time and ultimately ended up passing because she was misdiagnosed as having an infection of her breast and not having breast cancer. And so she ultimately had stage 4 by the time she was diagnosed. And this is a woman that I called to mama. That was my second mom. And so I was impacted by how primary care really could help someone or be a barrier to someone. And so I really wanted to change that for other people. And then I really wanted to work with women and children, and I fell in love with delivering babies as well. And family medicine is the only place where you really get to do all of those things. So that's why I became a family doctor.
I love it. Thank you. All right, Dr. Lambert, why don't you introduce yourself?
Sure. Hey, everybody. My name is Dr. Carl Lambert. I am a family doctor and a faculty member at Rush Medical College. I wear a couple of hats there. I sit on the admissions committee, and I'm the medical director for the Rush Family Physicians Group. And I direct the Family Medicine Leadership Program, which is a longitudinal experience for students who come in knowing that they want to do family medicine. And I faculty advise the SNMA chapter that's there. So I spend a lot of time guiding medical students who are interested in family medicine, and students of color in particular. So, I mean, where do you start? Family medicine, I love the relationships that you have with people. And I was always the kind of person that I would wonder what would happen to people, like during my rotations. Like I would have these great conversations and I always would wonder, well, are they eating their vegetables? Are they taking care of themselves? Did they follow up and did they do the things that I told them to do? So I always kind of had that sort of heart. And then I grew up with 2 younger brothers with autism. So we spent a lot of time going to Rush. We saw specialists at Rush when I was a kid, and I liked the relationships that they had with my family. They treated us as people, not like numbers, but as individuals with stories. So again, that's something else that really captivated me about the work that physicians can do. So I love combining teaching, mentoring, journeying with patients through highs and lows, and just kind of being that sort of confidant for people. So of all the specialties, I think family medicine allows you to do that from the cradle to the grave. And I wouldn't trade that for anything.
Perfect. Perfect. Dr. Krislow, please introduce yourself.
Hi, I'm Dr. Renee Krislow. I am on faculty at University of Minnesota, and the program that I teach in is the North Memorial Family Medicine Residency program. And I'm also the Director of Advocacy and Policy for Department of Family and Medicine and Community Health. And I became a family physician because I just thought that's what doctors did. I remember like the second day of med school. First day we didn't have anything. Second day we're all like walking around talking with each other. And I remember because it was like the last day I ever wore a dress. And I remember just being there and someone going, what's your specialty going to be? And I was like, I'm going to be a doctor. And they're like, what do you mean? I was like, I want to be a doctor that takes care of the people. And they're like, I'm like, I want to be a doctor that takes care of all the people. And they're like, oh, that's family medicine. I'm like, yeah, of course. I knew that. I totally knew that. Yeah, I'm going to be a family medicine doctor. And we had amazing mentors. I was at UC Davis Med Center, and they were just the most amazing faculty that were just so committed to people and the communities and the relationship. I think Dr. Lambert hit the nail on the head. It's like there's really something very special about being a part of a family in a way that you help care for them in many aspects. I love all the stuff. I love delivering babies. I love the fact that I've been doing this for over 20 years, and I see some of the people that I delivered, and they're at the point where they're having kids, and they can still be in our lives. And that's what's really amazing, is that you help people. Basically, we guide people through the challenges and choices of their lives, and we help them try to work in and grow into their best selves. And the good news is we'll take care of you if you would never change, and we'll take care of you if you change. Because the cool thing about family medicine is, you know, someone doesn't have to be sick to come to us. We can keep them healthy. And I think that's really nice, especially folks with lots of chronic illnesses. You know, they can come to us and, you know, one doc can help them with a lot of their challenges, you know, and it's really nice to be that person for someone who needs you. And so I think one of the reasons I loved it so much was because I like being of service and I like helping people out. And when times get tough and they look at you, you're just like, we're going to work through this together. And you don't, like I never promised to cure, but I think we can always heal. And healing is really about listening and trying to help the patient make the choices that are consistent with their values. And I think family medicine is one of the best ways to do that.
I love it. I love it. Thank goodness I'm recording this, guys, because this is wonderful. I love it. All right. Dr. Martinez, please introduce yourself.
Hi, hello everybody. I'm Viviana Martinez Bianchi. Until the end of May, I was the residency program director at Duke in the Department of Family Medicine and Community Health in North Carolina. And now I'm the director for health equity for the department at Duke University. I'm also a member of the executive committee of the WONCA, the World Organization of Family Doctors, and I'm liaison between WONCA, representing family doctors from all around the world, to the World Health Organization. I went into family medicine for several reasons. One of them, I always envisioned a career that will put together primary care and public health that I was looking for, and I didn't know it existed when I was a medical student, a place that will put me between that space that normally public health has it in place, this issue of prevention, this issue of learning the community, knowing what's going on, being able to be an active agent of change in the public health perspective, but I could never give up being a clinician, seeing patients. And when I learned about family medicine, it also met what I was going through in medical school, that I love everything I was doing. I loved women's health, but I couldn't see myself only delivering babies or only doing gynecology. I love dermatology, but I couldn't see myself only looking at people's skin and not like learning other things. I love the variety. I think when I learned, I love the variety of the emergency room, but I couldn't live with the idea of not knowing what happened with the interventions I did. Like if I treated somebody with pneumonia, I wanted to call them back, 3 days later to find out how they were doing. And the emergency room doctors are like, oh, no, you just leave that for the family doctor. Like, who are they? I want to know about them. Who are these people? And so family medicine became the answer to all of those things that I loved. I love mental health, and my goodness, so many issues of mental health come through family doctors. And so that was one part. And then the other thing is, in family medicine, I found that place that puts me in that intersection between primary care and public health. And to me, family medicine is my vehicle for social justice. It's being there when I'm needed, where I'm needed. I have done, in the last 10 years, I've been very involved globally, but right now my community needs me in North Carolina looking at the COVID response, because Latinos in particular, the Latinx community is disproportionately affected by COVID-19. So this is the moment when I'm here, feet on the ground, planted, anywhere from COVID testing to advocacy and working with the government on different task force, and the city and the university poking at the decision makers to make the right decisions for our community.
Love it. Love it. Thank you so much. And last but not least, I'm so glad you were able to join. Dr. Figueroa, please introduce yourself. Just who you are, and yes, why you chose family medicine.
Hi, everybody. Hi, friends. I love my co-panelists. That's the first thing I have to say. And I want to thank Dr. Matthews for inviting me to participate. I'm Evelyn Figueroa. I have been in family medicine for over 2 decades. I spent half of those decades helping run the UIC Family Medicine Residency program, like Dr. Martinez Bianchi. I also stepped down in March, although I'm still at UIC. I'm a professor there. Additionally, I do a lot of community-based work through a nonprofit that I run with my family. And we have two main projects. The big one is the Pilsen Food Pantry that is doing a lot of extra work during COVID. And then additionally, we ran a project at a homeless shelter where we sheltered in place for over 200 people. I chose family medicine like everybody else here because I like everything and I like relationships. Relationships are super important to me. So family doctors were different. Internists like relationships too, but family doctors like to touch and poke and prod things. So we, a lot of us, you'll find out, have hobbies, doing all sorts of other things, you know, home improvement, sewing, gardening, this type of stuff, because we just like working with our hands a lot, and we don't like to be limited to a specific population, and really feel like it is the answer and a way to take care of our patients and our communities. And that ability to love all the different parts of our patients and the problems that they bring forward also helps us want to return back into the community and pay it forward and do work to try to address structural and community problems that we observe. Thank you for the opportunity.
I love it. I love it. All right.
Oh wait, I meant to say, and I still deliver, and my last delivery was Friday night.
I love it. I love it. Dr. Krislow, do you deliver as well too? Was that the hand? Okay.
That was the hand.
Okay. All right.
Yeah.
I love it. Both
That
hands,
is what I did Friday. There was a shoulder, so
Yeah.
that's what I did.
You guys are good. You guys are good. All right. Let's get into the nitty gritty, because I wanted to, of course, share our own personal decisions about why we chose family medicine. But tonight, I wanted to make sure, especially for our fourth years out there, that's kind of the whole point of the conversation. I wanted to offer all of our advice about how we are choosing our residency programs, right? Or even advice just about applying, right? So let's kind of get into that. I'd love to hear from each of you. You've all been involved in different selection processes. What are some good and perhaps also some bad factors as to how students who are interviewing through your programs, how are they choosing the programs either that they're interviewing with or that they ultimately went with? I'm sure you've had maybe even some residents that chose your programs that maybe it wasn't the right fit. So let's give some advice about how we're actually choosing the program that we go to, right? Because there's many different choices out there. Anybody in particular want to start? Yes, please go ahead, Dr. Krislow.
Well, I think one of the things you have to understand is they call it the match for a reason. There are, over 400 programs in the country, and they all pretty much ascribe to certain baseline rules. And as long as they're doing those rules, you're going to get good training as a family doc. But what you really want to do is it's really an opportunity that's a little different this year under the pandemic, because typically you go there and that's how you feel. I mean, I remember interviewing in last millennium, and I remember walking into one place and I'm like, I hope they serve lunch early because I don't want to stay. They didn't. It was a very late lunch. But this is the thing. I've taught at 3 different residency programs that are actually quite similar in a lot of ways. But every time I could just feel like this person fits into our family. And like in Minnesota, we have 8 programs, and they're all have their own slightly different flavor. So one of the things that I say, especially this year, it's going to be a little challenging because there's not the travel thing. Get an opportunity to talk with the residents. See if these are the people that basically you want to be. The way we think of it at North Memorial is like you're joining our family forever. Yeah. It's like, are you part of this legacy? Are you part of this destiny? And folks that come to see us, they all are hardcore in full spectrum and social justice. And and we have folks that do sports medicine and rural medicine, and they're still hardcore in social justice and full spectrum. We have, I remember one of our definitely headed towards sports medicine guys wanted to go to rural Minnesota when he was done. I remember him coming through from didactics at one point, and he goes, "How come no one told me about white privilege?" And he was just like, "I got to do some stuff." I was like, "Okay, we'll help you." And that's the thing, though, is like, what is it you're going to learn there? It's like, you're all going to learn family medicine, but what are you going to learn about, the kind of doctor you want to be? And so I think talking with both residents and, if you can, alumni of the program, are they doing the kind of things that you want to do? Because, like I said, they call it a match for a reason. And that's sort of my big advice, is like, see if you actually match these people.
Perfect. Dr. Martinez-Bianchi.
Yeah, completely in agreement with what Renee was just saying. I think this is a very different year because you can't be there to feel that, to have a sense of in-person. I remember loving the curriculum of one program over the other, but when I was at the one program where I loved the curriculum and I went out for dinner with the residents, they were talking about the other program and they were saying as negative all the things I love about the other program. So I'm thinking, okay, wait a second. They think that program is weird because of that, but that's what I loved. Maybe I will be too weird here. It didn't matter that the curriculum seemed more appropriate. It was more about fit. So this year is different because you don't have the chance of being there and sitting in a relaxed atmosphere at a resident's home or at a dinner. But you do have the opportunity of going on Zoom and talking. The other opportunity you have is looking at their website. Some programs have residents who have been bloggers. Some programs will tell you, just look at the flavor of what you're seeing. There's a myth with your own, are you excited about what you read? Are you not? Does it push you back because maybe it's too social justice oriented? Does it pull you in because it's more full spectrum? Does it pull you in because it's more of a religious program? So review what is going on in the website and have a sense of that flavor and how it fits to your core values. Otherwise, if you really have enjoyed family medicine, you're probably going to go well in the majority of the programs in the whole country. But it's about that extra flavor that I think is key as far as fit.
I know I personally, and actually I didn't even introduce myself at the beginning. I'm Cameron. I'm another family doc. I'm currently at the VA, actually, central office in DC, working in administration. And on Sunday, I'm actually starting a whole new position that's kind of daunting. I'm going to be the new chief medical officer of Veterans Health Administration nationwide. So yeah, so family docs, we do everything, guys. So we can definitely talk about kind of policy and administration and all of that. But I know I personally, I chose my program because of Dr. Figueroa. But she was one of my faculty mentors. I adore her. But no, completely agree with the fit. For me, just even then narrowing down, okay, how do I choose which ones to really get to know? I ended up flipping my list. I don't know if anyone else had that experience. I thought I was going back to Philadelphia. I thought I was going to be with my parents and I just needed them to bring me groceries and to cook for me. And I just needed them, for that kind of support. And then I realized how much I felt really connected to Chicago, how I loved the program. I did, a sub-I at UIC. And then I just thought, I'm never going to see my parents, even if we live in the same city. So why don't I just go to Chicago anyway? So I ended up changing up completely. But for me, it was both fit and then being somewhere where I felt like I was home. So there was, the fit at work, but then also living in a city when I knew I would have maybe limited free time, at least in the beginning. I wanted to feel like I was home. That's what I thought I was reaching for in Philadelphia, but it really ended up being Chicago. And so didn't regret it at all. Any other thoughts? Go ahead.
I have a few. That was really nice, Kim. So when I was at a dinner a couple of years ago for Society of Teachers of Family Medicine, and there was a third-year resident sitting across from a fourth-year student that was on STFM's board. They were both on the board, and the student was asking for advice from the third year, and she said, "Oh, how can I tell programs apart?" And the third-year resident said, "There's nothing, they're really basically all the same. and just pick where you want to live. And it was such a shocking thing as a residency director at the time. And I didn't know them, and I didn't want to kind of like knock on the door and say, that's not true. 30 blocks of the 36 months of residency they're all characterized in the same way. But all the programs fulfill those requirements differently, depending on whether you're suburban or rural or urban. And if you're urban, what is your target population? Whether you're faith-based or non-faith-based, whether you have a big Medicaid population or not a big Medicaid population, if you're a university or a community program. Of course, the flavors are completely different for all the programs. Yes, you can get sort of a generic residency sort of everywhere, but the whole part about having that fit and feeling a connection to the population that the program is serving is super important, because residency is really hard. And you have up to 80-hour work week. You get 1 day off a week. That's the rules. And as a residency director, I tried very hard all the years that when people could get, only work 5 days that week and not work Saturday or Sunday, that was great to be able to do that. But at a minimum, you're there 5 days a week. And at a minimum, even best case scenario, you're working 50 hours a week. That's best case. That's a good week, right? So you have to love the identity of that program, because there are going to be times where you are going to hate, you're not going to want to be at work. You're going to go, what did I do this for? Because working 80 hours a week, although we normalize this discussion about 80 hours, it's a huge commitment. And if you're on inpatient service, pretty much everybody on inpatient is doing 70, 75 hours a week. So you have to want to connect with this vulnerable population. Like if you're at UIC, I always recruited saying service has to be in your heart. We take care of twice as many Medicaid patients. If that safety net is not really important to you, this is going to be a very challenging environment to be in. And fortunately, we have people like Cam, and people like Dr. Krislow and Dr. Wheat and Dr. Lambert and Dr. Martinez Bianchi. There are a lot of us who that was what we wanted to do. We wanted to go somewhere where patients didn't know that they could have a choice of who their doctor might be. And so that we could be an extension to advocate for them. So when you go and you interview and you go online and you look at it, you can really see a program's values and see what they hope to promote, what kind of people they want, what kind of doctors they want to train you to be. So I agree with the web searching. I do think that I'm literally making a note, even though I'm not residency director anymore, thinking about this, the different ways we're going to have to adapt. I've definitely done it for the nonprofit, but we're going to have to do it a lot more online. And if a program, one of the things I always talk about is, I saw some comments like asking about connecting with alumni, all of that. Those things are very important. So when you're interacting with a residency program and you're asking them for that information, the residency program should try to give you that information. Now, if you're asking for checking account numbers and Social Security, no, of course we're not going to do that. But if you're saying, I want to talk to someone, someone who's graduated, I want to connect with that person. If you have a lot of trouble connecting with the program, that, this is us on our best behavior. You do have to be forgiving, because we're going to have a lot more email traffic than we have in any other year before. But do recognize that, this is us dating you. So if, you have to, if that website is a skeleton and you can't tell what the program is about, that can be a flag.
Great point. Yeah, Dr. Lambert.
Yeah, I love everything that's being said. I'm glad this is recorded. I gotta listen to this. I already went to it. So I agree that it is like dating someone. So a fact about me. So when I graduated from Rush, I was the only Black person in my whole class of like 140. So when I graduated, I was really intentional. Like I was not playing around about culture. Like if I go to a program, am I going to feel safe, right? Is there anything in the curriculum that has to do with like microaggressions? And even if everyone doesn't quite look like me, is everyone down with the mission? So certainly look at the website and look at what their mission statement is. What's the value? Who do they serve? So I picked a program that serves like the Austin community, which is really underserved. You get to work in FQHCs, and I went to a program where I did not feel like I stuck out like a sore thumb. I felt like my presence was an asset and not necessarily a liability. So I think that's super important just for your psyche and just from the day-to-day grind that residency brings. It's hard. And then also I wanted to pick a program that I knew would be rigorous, that would kind of kick my butt, because I just had this fear that I knew most residency programs are 3 years. So I wanted to make sure that I would be ready to do anything that I wanted to do after 3 years or so. So you want to pick a program that gives you that sort of comprehensive training. And you should think about, where do you want to be after you train? So you should have some sort of vision about what your career will be. And then the other thing I wanted to add, I've heard a lot of good stuff, but I had a couple of bad things that I wanted to add. So sometimes students will kind of choose family medicine almost like a last resort. And it can come through when you do interviews or when you read personal statements. So make sure, if you're picking this specialty, that it's for real. Like it shouldn't be a backup plan. It should be your heart's mission, or else we can smell that sort of thing. Mm-hmm. And then the other thing is, make sure you don't wait too long to realize that you're interested in family medicine. So as you go through medical school, try to find a mentor. Look for opportunities to experience family medicine in multiple settings through people in your school, mentors, national conferences, and the like, or programs like this. So just make sure you're really well informed about what this career and what this specialty is about.
Perfect.
I could
Any
add
other?
just,
oh, go ahead. Perfect.
Sorry, I'll start with the bad and then end with the good. As a program that's named Northwestern, the worst applicants I get are the people that go, "Oh, I'm applying to your program because you're Northwestern, so it means you're really university-based and research." And I'm like, "Oh, you really didn't even look at my website at all, because my program has nothing really to do with the university. It's all about being at an FQHC." So I would encourage you to not just apply to 50 schools because you don't have to pay to travel this year to interview. I would encourage you to actually get to know that program, because if you don't know anything about the program and then I'm interviewing you, I'm going to feel like you don't care and you're not invested in being there. And so you will not be my favorite applicant. I was fortunate to also have Dr. Figueroa and Dr. Matthews as people at UIC, because I went to medical school there. And so I got to talk to them as I was going through my journey. And they both really talked to me about the mission and where your heart was. And that is something that I really sit with. That is something that I think is super important. The mission of the clinic, the mission of the residency. To Dr. Figueroa's point, this is really, really hard work, and you have to love what you're doing. You have to be invested in what you're doing, because you're spending so much time away from your friends and family doing this. It is all worth it, but you have to want to do it. You have to believe in the people that you're with. And there's also being around other people that have similar ideals to you. So if you're going to a program that is focused on underserved care, are there mentors there that believe in it and will support you in doing that? If you're going to a program, or if you really want to do sports medicine, are there people there that can support you in that and can show you how to do it? And if they aren't there, do they have connections to help you get there? Knowing those things, like Dr. Lambert said, that you maybe want to do in the future, help you in finding out who those mentors can be for you.
Perfect. Any other quick ways that you might differentiate your program from another program? So we talked about the patient population. We talked about, obviously, the residents that are there. You can, of course, say the faculty that are there. Any other points to highlight? That's one question that Maria has in the Q&A. How do we differentiate the programs? Dr. Martinez-Bianchi, go ahead.
So some programs are going to be community-based, meaning a community hospital. Some programs are going to be linked, and where most of the care is done in a federally qualified health center. Some programs are going to be part of an academic medical center. I personally hate the idea of opposed versus unopposed, because who's opposing you is other than, it depends. In some academic medical centers, you may not have the opportunity to do as much as in community-based programs, but there are some other academic medical centers, like I mean, all of us are linked to an academic medical center where you are actually a member of the team, regardless in what service you're working or learning from. And then you also have your own family medicine service where you're calling the shot. So just look at those things. And again, I think it's a flavor of, do I see myself in a large city? Do I see myself more so working in a federally qualified health center? Do I see myself in a combination? Some programs, so sorry, my dog loves to talk when I talk, so he's in the background. But sometimes there may be programs where they have a combination of both things, where you have the opportunity to work in an FQHC, you have the opportunity to work in the academic medical center, and then you have other rotations in more of a community-based hospital. So you're going to find all of these different variations within family medicine, and look and see where does it seem to feel more comfortable.
Perfect. Perfect. Yep. Yes.
Just briefly, the other thing is that there are some, besides the very easy split is looking at the clinic populations. Then there are other co-curriculars that can happen in residency. So for instance, Dr. Martinez Bianchi at her program had a huge public health track, because when she became residency director, it was important for her. She was like, this is just, we should be doing this. So she's always been very much ahead of the American training crowd. And she brought the residents and then dragged the faculty in with it, and really just, I mean, it was just amazing to see what she was able to do. Our program has a very large LGBTQ health program. We have, we do gender affirming surgery clinics. We provide, hormone treatment, etc. We do abortion care at UIC Family Medicine. So you can find lots of different things besides the diversity of family medicine. We're all going to take care of children and adults, and there will be maternity to a certain degree during the residency because those are ACGME requirements. Then you can look a little bit more than that. And besides, when I talk about abortion, there's also IUDs and arm implants and that type of stuff. So if you're someone who's interested in those things, if you're interested in higher risk maternity, then you're going to try to see if the programs that are where you want to be and around who you want to be around, if they're going to offer you that training while you're a resident. So, if you do decide to do fellowship, that's totally fine, but hoping to get as much of a taste and exposure to the idea of family medicine as you see it as you can during your training.
Great follow-up question here I'm sorry, Dr.
No,
Krislow,
go ahead.
This is a great question, because maybe some students may not understand. Is there a way that academic versus community versus FQHC, do they train you differently? Because we're naming these different, yes, go ahead.
Okay, so this is the thing is there's not a really good blanket way of expressing that. I'll give North Memorial as an example. So North Memorial Family Medicine Residency Program, we are a University of Minnesota program, but our hospital is a community hospital. It's North Memorial Hospital, it's a community hospital, but it's a community hospital that is a level 1 trauma center and the highest level of NICU. It's a community hospital where our residents are the only residents in the hospital. They've trained family medicine docs there for over 50 years. Every specialty that's hired there knows they're going to be teaching family medicine doctors. And our clinic is not an FQHC, but we serve the FQHC population because Minnesota is one of those places where we have a massive social safety net. And so people who would be in FQHCs in other states are actually on Medicaid in Minnesota. So you can't sort of do blanket statements about that. And we also, a lot of our graduates work at FQHCs in the same neighborhood that we serve, and we admit all of their patients to the hospital. So we actually take care of FQHC population, high Medicaid population, and we're a community hospital, but we have all of the advantages of a university program. And so it's one of those things where you can't really do cut and dry. What I think is what you need to think about is the level of risk that you want to be engaged in. Do you want high risk populations? Do you want a population, does the hospital that cares for where you train for the family medicine residents, does that hospital have a high volume, trauma service? Because places that have that kind of necessity get you lots of full spectrum training. It's just because it's the volume. And do you want to, what kind of OB do you want? Do you want high volume or do you want high risk? Because, you know, we have probably moderate volume, but every single one of our patients would be considered high risk in other places. So it's really about getting the story of the hospital more than just the labels, but ask the questions about it. And then she's like, what does that mean for your hospital? So that's the kind of things that I would think about.
Perfect. Perfect. Go ahead.
I was going to address that variation too. Like in our clinic also, we have the very high risk population on Medicaid, but then you also have to explain diabetes to somebody with a very low literacy level, and then to a postdoctoral fellow who knows about receptors you don't even know exist yet, right? So there's also all those variations that come within different settings, and they can make it really fun, and it can make it stressful too, because you're having to speak the language of illness and disease and diagnosis to such a variety of people. But it is what makes being a family doctor so really, really exciting as well.
Perfect. Perfect. All right. I love this question because I think it's fitting for the panel and the audience. How do we differentiate a program that takes diversity seriously? How can we gauge how they support, you know, diverse students, especially now that we're not visiting in person? I mean, is it enough just to look at the website? Is there some other way that we can assess that? Who wants it?
I'll start. I would start by asking, and I would ask everybody and see if you get the same answer. Are you getting the same answer from the program director as you're getting from the resident? Because I hope that they will tell you the same thing and will have communicated as a residency community that they're all on the same page. And then if they're not, then I would ask them why it's different, especially if you get a faculty member before you get the resident, then maybe you can get a little bit more of a story. I wouldn't necessarily say that I would look at a program and say, oh, there's no diversity right now. That doesn't mean they're committed. I care more about what they're doing to change that. And can they acknowledge that there's not enough diversity and that they are implementing steps to make change?
For many years, people ask, is it safe to be a Latina at Duke? And it's like, I'm the program director, I'm a Latina. And that in that way, I ended up recruiting a lot more students that were Latino, Latina, Latinx. And it was amazing for me to see this group of people coming from all over the country. And at the same time, we were really invested and committed on true diversity. So if you look at the website, if you look at our faculty, you will see that we have a program director who is white and 2 associate program directors who are Black. And so the diversity of the faculty is also important. And it's also what we are doing to make it better. Evelyn, Dr. Figueroa was just talking about LGBTQ issues. You know, we also have a gender-affirming clinic. We are paying attention to that. We created an LGBT center medical home. I really think it's looking at the trajectory, and also, like Dr. Witt said, and what are the changes that are needing to be made. That it is safe for us as faculty sometimes may mean that when we are paying attention to issue, for example, Latinos being disproportionately affected by COVID right now, that I actually can have a voice and I can be promoted to a position of being allowed to speak clearly and outwardly about this in my department and in my university. If you didn't see me talking about this when 70% of the cases are Latinos, you will have to say, there's something wrong about this. There's what is going on that this is not being, called out in a better way. And the same for so many issues that had to do with equity and racism and those structural things that we all care about. knowing what's going on and what people answer. And sometimes they may, not everybody may know what are the issues are, but they will know how safe does it feel. Are there people who are committed to this? Do we have champions within the department, or is it the whole department is a champion against racism or against LGBTism or ethnophobia, right? What is going on in that department? Those are things that you want to see.
I just would piggyback on all those. And I honestly, one of the questions I would ask now is, especially if you're looking at a program that is in an underserved or low wealth community, I would say just explicitly, what has your program done around COVID-19 with your community? I would also say, what has your program done about Black maternal death disparities? Yep. What have you been doing? And if they're like, well, we thought about, it's like, just ask the big questions. There are big structures that are in place right now that are really revealing how messed up we currently are. And as family docs, we feel a personal responsibility in working with our communities and making the difference. And if you see a program that's not quite getting the level of involvement that you would like, then you need to look elsewhere. It's one of the things where when we used to go to Kansas City and recruit back, pre-apocalypse, people come up and they're like, what do you guys, do you do anything for advocacy? Do you do anything for, community outreach? And it's like, we would just sit there and just rattle off things that we've been doing for, 9-10 years. And people were like, oh, wow, this is the first time someone said that they're actually doing something. And there's more and more people that are doing it. So and I like the idea of understand that some people are they're on the trajectory. They're trying to make the difference. They're trying to make the changes. But if they're on the trajectory, it means they've thought about it and they should have an answer for you. And the first thing that a lot of places should say is, yeah, we don't have enough Black and brown faculty. And they should say, yeah, we may actually try to make you one of our Black and brown faculty.
There we go. And
if someone says that, they're invested in you. So it's really about asking the real questions. What are they doing they're in their communities right now with COVID, and what are they doing with, things like Black maternal and child death? They're not easy answers, but they're easy questions to ask.
Yeah, I agree. So that is what I heard when I went around, like, we want you here at this program. And then also I would ask who's involved in the selection of residents. So I would specifically ask like underrepresented minority residents that I was able to reach out to prior to signing up or making my rank list to say, okay, well, do they listen to your voice? And also, I hope you're not the only ones that are championing diversity. It should be shared amongst everyone in the program. So I would ask explicitly, what is everyone in the program doing to kind of move this forward? Like again, like many people have said already, what is your plan? Like, what do you hope to accomplish over this year? So hearing a plan is what's encouraging to me, especially for people who want to engage in this work, but they just don't quite know how. At least a plan is needed in the times that we're in.
Perfect. All right, let's jump to some of these questions. I love this one because I think we discussed it a little bit, but could anybody comment on what common or uncommon pathways as far as fellowship are after residency and what specializing in quotes looks like? The person's asking particularly about maternal fetal medicine, but if any of you did fellowship or could speak to maybe any of your residents that have gone and done fellowships. Dr. Figueroa.
All right, well, first things first, family medicine is proudly the least specialized specialty. So we pride ourselves on not specializing. Now, the last report I saw was that 4% of family physicians do fellowships and that 2% of family physicians do ACGME accredited fellowships. So it's 1 out of 25 that do a fellowship overall, and only half of those are doing ACGME accredited ones where they're getting a CAQ afterwards, a certificate of added qualification, or sitting for some sort of boards, testing, things like that, like HIV medicine, something. So just keep that in mind. Like, we try as hard as we can to get you out into the workforce and serving, and we want you to stay as broad as possible. Now, that stated, I did a lot of extra maternity care at my first job after residency, so I didn't do a fellowship, but I did marry a person by coincidence through teaching also at Carl Lambert's program, because family physicians all know each other. Like, we all know each other, and it's really nice to see everybody today. It's so nice. Especially because this week is STFM and we all can't see each other at STFM, so it's really tragic. There are several, for instance, in Chicago, maternal fetal medicine opportunities. The biggest one is at West Suburban. There have been a couple other fellowships in Chicago, but West Sub has an over 20-year history. I think they're at 26 years or something like that at this point. My husband, Alex Wu, is the fellowship director. So Jasmine, I actually know the person who sent the question, and she's one of my advisees. So Jasmine, it's clear I have to connect you to my husband, which we can do right after this call. But they spend that extra year learning to do higher risk care. So it's not vaginal deliveries. Most high risk fellowships, whether it's University of New Mexico or Contra Costa, what's the one there's another one in California that's really, really busy. I'm trying to remember the name. Anyhow, these programs are to learn to manage high risk and do cesarean deliveries. So they're not for vaginal delivery. So the program that you go to for residency, you do not want to pick an OB light program. You don't want to go to that program to try to get more vaginal deliveries, because they're expecting you to be running the floor and being the attending for normal deliveries, and then getting more improved at quality improvement, information systems, et cetera. And third degree repairs, fourth degree repairs, extraction of placenta, et cetera. And then a lot of newborn nursery, so neonatal resuscitation that goes with it. There are some residency programs that will give you everything short of the cesareans. It's now required that you do fellowship at pretty much every single hospital to get cesarean privileges. So that is pretty typical. There are certain people who've been grandfathered in because maybe you trained in Peoria, so you did 100 C-sections during your residency. Some of the fourth year programs, for instance, in what's the one? Lawrence has a fourth year that they get to specialize in maternal child health. So it's incorporated into the residency, but it's also an extended residency program. Renee, some of your folks do sections, don't they?
Yeah, so at North Memorial, over the last probably 45 years, a third of our graduates have gone rural, and at least 20% of our overall graduates still do deliveries through most of their career. And the way it's often worked for folks who've gone rural is that it's like Dr. Figueroa says, we get you the number of deliveries and high risk laboring so that you can do pretty much, and you do first assist on every single C-section while you're on service. And what we found is for the folks that went rural, they get section trained by their partners. That's the way it had been for quite a while. A lot of people are now going off to fellowships, but for quite a while it was you did a lot of high volume in residency, and then when you got into your rural practice, your partners would train you for sections. And I think one of the things that you have to, if you want to do sections, you have to think about where you're going to live, because most places that are urban in this country, it's very impossible for a family physician to get privileges. So if you want to do sections, you need to start thinking about where you're going to be living. It's not impossible, but it's close to impossible for urban areas. If someone does tell you that they have had grads do that, ask to get permission to contact that grad, because you're going to want to do what they did. And as Dr. Figueroa pointed out, we like to raise you to be full spectrum and do as much of wide practice as you can. But there are some extra training you can get. One of the things that I did a health policy fellowship, primary care health policy fellowship through the Department of Health and Human Services. And it's played a big role in my career in allowing me to honestly teach advocacy at a larger level and engage in advocacy on a national level in addition to our state. And it was, the reason I did it wasn't that I didn't feel like we didn't get training in doing kind of advocacy. What I did it for was to get the language of the policymakers and to get the pathways that they understand. So if there's something in particular you're very interested in, sports medicine, sleep medicine, all these kinds of things, a lot of folks that specialize in family medicine actually just increase that area within their own practice. They may still do full, babies to grandmas, but they may actually be the ones that their partners send to do the knee injections and things like that. So specializing in family medicine is a little different than other places. And the best part about it is you get to make the career that you want because you have the training to be so wide. And if there's an area like women's health, like there's a lot of folks who are trying to choose between OB-GYN and family medicine. And the thing is, what I ask them is, how do you feel about surgery? And if they're like, I live and breathe surgery, and I'm like, you are a gynecologist. And if they're like, I don't really care about surgery, I just like doing deliveries and taking care of women's health, you're like, you can do all of that in family medicine. So it's like you have to figure out what the slight differences are and how you can actually get that training. And we're all here because we're crushed out on family medicine. It's awesome.
Love it. Yes, we are. Yes, we are. All right. So I think this question is nice and big enough. I know we got a lot of really focused questions. Thank you guys for sending these. But how do your programs filter through all of the applications? How are programs actually choosing which residents? I know Dr. Weed actually kind of, pointed out, don't just say you want to come to Northwestern. Like you obviously, that's a kind of big negative, on the checklist. But when the application pool is so big, how can these students stand out? What can they do to get into your program, basically?
I read every single one.
There you go.
Yeah, I read every single personal statement myself, and it's a lot. And so I really want you to speak to me in your personal statement. That's the first thing that I read. So if you can sell to me why you are really interested into family medicine, number one, and particularly for my program, interested in underserved care, then that is going to get me to review the rest of your application. If you don't have those two things, then you're probably not going to be happy at my program, because I don't just want somebody that, I don't want to just train you. I want to train you and have you be happy and to continue doing the work that we're doing. And so I want somebody that is going to sustain the 80 hours a week for 3 years and love what they do. So I want that to come through in your personal statement.
Perfect.
We look at lived experience. It's not so much, it's not about the grades, it's about what have you done. Were you the best student in your class but didn't do anything else? Then more likely you're not going to be the best applicant for my program. We are going to prefer that you were maybe a moderate student, but you actually did all these other things that speak to our what we're interested in. Were you active in your community? Were you doing community engagement? Were you doing work that was related to that advocacy? Were you involved with Teach for America? Were you involved with, or did you grow up in a different type of home where you had to work through college and medical school and that reviews that, I mean, there's so many variations of that, but we tend to look for the people who have had some lived experience that is consistent, often with the lives of the people that we care for, or that you have passion for caring for people who are more, they're members of vulnerable and underserved communities.
Perfect.
Same for UIC. It's one thing that I instituted, I think 2 years before I stepped down as residency director, is that everyone had to have a job before, because sometimes you will, I was someone that even though I started residency when I was 25. I started medical school when I was 21. I'd had a job since I was 14. So no, 13. So I'd always had a job, and even during the academic year from age 15. And I think that that was a really helpful thing that I learned. It was, sometimes residents get upset in the call room. They go, someone should do this. And I would look at them like, you are someone. Like, if you don't like how something is, like, what are you going to, like, it's, 10% inspiration, it's, it's 90% perspiration. There are lots of thoughts and prayers going around our country right now, but where's the change? I really wanted to be surrounded by young learners, young trainees that understood that if they wanted to see things change, they had to be part of that. So no job was too big or too small. This doesn't mean I want the residents, rolling patients to CT scan or anything like that. It doesn't mean that. Because that is prohibited, and we have transport. It's just a matter of them understanding that we all have to own the problems that our patients have, that our communities have, and do their best to be part of the solution. So that was one thing that was very important that I looked at in applications. The other parts, fitting the fit for us was super important. So if someone was AOA, but the rest of their application didn't have anything, it didn't matter. I wouldn't even interview them. And the few times that I did, where the person wrote, I'd say, tell me why this program. And then I wouldn't get an answer that made my partners applying in Chicago or, this. I'm like, that's not a reason to come to our program. Like, you're not going to be happy. If you never, if you don't care about homeless people, coming to University of Illinois is going to be really rude awakening for you. So you really, like, that those parts shine through, and you can write things in a personal statement, but if the personal statement doesn't really translate to the rest of your application, it's going to be challenging. Now, don't despair. There is a residency program for every American student and for a ton of the international students. So you don't have to worry that you're not going to match, but trying to force if you don't really resonate with a program's mission and their values, you're just spending a lot of time and emotional energy into applying. So I strongly encourage you, being in an interview that is uncomfortable for you, it's not like 20 minutes, it's 5 to 7 hours you're going to be with these people. And it's very hard to sustain if you're not feeling it.
Perfect. All right. Do you guys mind if we go a couple more minutes? I know it's 8 o'clock and I want to be respectful. If any of our panelists need to drop, please, by all means, but there's just a couple of great questions if you guys don't mind.
I think you wanted to say something though.
Oh, I'm sorry.
No, I was just going to add on to that because somebody asked a question in the Q&A about the board scores and how it fits into this. Mm-hmm. And I was just going to say, I have a lot of residents that have not passed their USMLE on the first time. And personally, for me, I can't speak for everyone, that is not a game changer for me in any way. What I do want to know, though, is what you did differently the next time, or was there something that was an extenuating circumstance that made that happen? If you failed and then you didn't learn anything and you were just like, oh, the test just got me down and I didn't study any differently, I didn't do anything any differently, then that doesn't help me help you, I guess. I just want to know that you learned that either there was something that happened in your family that was very different that happened that one time, or you just didn't know how to study for this test and you changed the way you responded. Because what I want to know is that when things are hard, when you're here, you're going to know how to change your learning style. You're going to know how to work hard to move forward.
And tests are just necessary evil of being an American physician. This is just part of the game. It's unfortunate, and there have been major strides this year, right? Changing step 1 to pass fail is a move in the perfect direction, because I think that anyone who gets into medical school is smart enough to be a doctor. We shouldn't be weeding people out once we get to medical school. That does not address the physician shortages that we have in this country and in other countries around the world. So the fact that we keep building all this competition is not natural, and I don't think brings joy to any of us. But I do think that while we're here, that I like Dr. Weed, it's very important for us to learn from our setbacks and potentially our mistakes, so that we can, really not waste a lot of emotional energy and finance and time, and bounce back from it and learn and move forward.
So true. Dr. Lambert?
Oh, sorry.
No, you good? Okay, good. I just wanted to make sure. You wanted... All right, so keeping with that, are there board score cutoffs? This question just came in. I mean, yes, step one's going to pass, fail, but does the same thing apply to step two? Are you guys, considering all the scores coming in and looking, more holistically as well?
Can you
Go ahead,
hear me,
Dr. Yeah,
Matt?
you're breaking up a little bit, but I can hear you.
Can you hear me all right?
Yep, there you go.
Yeah, so we look at all the steps as pass fail.
Oh, okay.
Yes, we've studied our best graduates, no correlation with board scores.
Mm-hmm.
So we just do it pass fail. If you passed it, we'll not hold it against you that you may have failed it at one point.
Perfect. Dr. Martinez Bianchi, you had your hand raised. Do you want to add to that?
Yeah, I was gonna say, if you didn't pass step one and then you retook it, I will advise to try to pass step two before, like trying to have, I think it's hard for programs to say, I will rank, to rank somebody who hasn't passed step two yet. So,
Mm-hmm.
so especially if you didn't well, try to get the step two by match day into the system.
Oh, okay.
That will be
so timing of it. Gotcha.
Yeah, so the timing is really important, especially because then it creates a risk for the program that if you were not to be able to pass, then you wouldn't be able to start in July. So really, if you didn't do well, or if you are somebody who has a little more trouble with test taking, try to get the tests done before interview season as much as possible.
Okay. Good question. I love this one. How do program directors feel about Black applicants wearing natural hairstyles during interviews with all my curls? How do you guys feel about it? I think it's fabulous.
I love it.
Right.
If you go to a program where natural seems to be looked at wrong, then maybe that's not your program.
There
right?
you go.
If you're going to be walking around and your natural hair seems offensive to anybody, maybe that's not where you want to be.
Love it.
Absolutely.
Done. I love it.
I actually tried to institute like casual dress for interviews. It ended up just confusing the applicants. But a few years ago, I said, you can just be business casual. I mean, we all are. So I felt badly. These poor students were wearing these suits when we were all wearing cardigans and, and corduroy pants. So some of them do it and some of them don't. And then we had a resident graduate last year that, she had a very large undercut and visible tattoos. I remember going, I love those. She's like, oh, my parents told me to cover it up. I was like, no, you get bonus points for all of that with me. Let's challenge the construct of what is professional. What is professional is you coming to work and taking great care of patients. And being engaged in your work. Like what you look like. I mean, I don't want you, it's important that you engender trust with your patients, but a lot of patients recognize how arbitrary and classist all of this really is.
So true. All righty. Let's see. This was a good one about personal statements. Some programs list specific criteria about the program that needs to be mentioned in our personal statement. Are you guys aware of this? Is this pretty strict? Most of us are using one personal statement to apply to all family medicine programs. So how should we deal with I guess customizing a little bit, but also being kind of efficient, especially during the stage where they may be applying to many programs? What would you suggest to that student?
I don't think you need the extra work of having to customize to every program. I do think that once you get an interview that you want to know about the program, that's when you customize your interview. I really deflates your opportunity when you're talking to somebody and you obviously haven't even looked into, what kind of program we are, where are we located, especially now that you don't get to travel, learn more. You have time, the time that you would have spent in airports and finding hotels and things like that, spend them studying the programs where you're going to be interviewing at.
Perfect.
I agree. I mean, if you get so fixated on having to get all these criteria, it can almost make the personal statement look canned, which you don't want. So you want to just speak genuinely and try to hit the tenets that are kind of core to family medicine, like continuity of care, caring for patients who are vulnerable, speaking from experiences and your own personal narrative. And if you're able to do those things, it tends to not steer you wrong.
Yeah, and I can say, based on 10 years, and we have somewhere between 1,100 and 1,500 applicants a year, that it literally does not predict anything when they personalize the personal statement like that. I have not found it to make that person significantly more prepared than other people interviewing that day, and certainly not more likely to match with us, both on their end with their match list and us with our match list. I think it's just that person just shows that they have more time and that they're trying to use this for finessing it. And that's fine if that person would like to do that, but I haven't found it to actually make the application any stronger.
I also want to add, I see every now and then the personal statement that describes family medicine. I don't want to hear the description of family medicine. Describe how you fit in that description of family medicine. Write about yourself, not about what family medicine that is. How do you feel about family medicine? What makes you love that aspect of family medicine? But I often know that the sense goes together with, this was not family medicine as a choice. It's more like, I read in between the lines, you're trying to convince yourself that this is something you like. And then I figure out, maybe a letter of recommendation comes on that it was actually recommending that person for a different specialty that wasn't family medicine. It's like, that's what I was reading in that personal statement, right? Exactly. So really be genuine about why is it that you want to do it. And we don't need to be convinced about family medicine. We need to be convinced about you.
Right. All right, guys, I'm going to go ahead and close this out. Thank you so much to our panelists. This was an amazing conversation. It is being recorded. Hopefully you guys don't mind if we share this with some of the students that missed it. Thank you we had 44 attendees, guys. This was great. And I think they got a lot out of it. So thank you for all of your time. Please, if any of our panelists feel comfortable connecting with students, only if you are, feel free to drop your email address. I'll drop mine. Please feel free to reach out to us if you guys have any questions at all. And with that, I will close it out. Thank you, guys.
Thank you.
Thanks,
Bye.
Dr. Matthews. See you guys.
Of course. Thank you.
Thank you.
Bye-bye.